Okay, welcome everyone. Welcome to the webinar. Tonight's webinar is on new updated ultrasound templates and also on report writing. I'll be showing you the changes that I've made and some case examples and practice some report writing with those case examples. Okay, so let me pull one of the templates here. Oh, not this one. Yeah, here. So I have elbow elbow ultrasound template, and it looks similar to the previous one. I just made some changes on the text here, the format that you see here, and again, this template is based on the guidelines AIUM practice parameters. AIUM is American Institute of Ultrasound and Medicine, so it is based on AIUM practice parameters and also based on standards of musculoskeletal ultrasound. Article published in Journal of Ultrasound. So it's based on these two important documents. And again, this is a template, so this is a document which will be changed for every patient and every scan that you will be performing. So you can change it based on what type of presentation you see, or what type of complaints the patient has. And as you can see here, even in the text, so there is a standard text that goes after MSKUS finding. That the examination was performed based on clinical presentation, and that's a very important part of the report. That every report is tailor-made to the patient's needs, and also based on what kind of question has been asked. If you are the one who's treating that patient, then you identify the need, or if that patient is coming from somewhere else, then you have to answer their questions. So you have to make sure whatever report you write has to answer the question asked, and also has to be based on what type of presentation you see in that patient. You once you have these templates, just save them, and you can put your header here so you don't have to copy paste again and again. This is the same name, date, date of exam, date of birth, gender, and the type of exam. Then this is the space where you will write why you're doing this test and what type of presentation or important information from your physical exam. That'll be part of this. Comparison, if there is any comparison with previous imaging done on this patient. Technique is you can leave it for pretty much every patient, except you have any other probe other than linear probe. So as you can see, it says a frequency range of 6 to 15. So I know some people have a curvilinear probe. So if you're doing hip and you're using curvilinear probe, you will have to change this frequency to match that. So that'll be like 3 to 5 or 2 to 5 megahertz, whatever frequency of ultrasound probe you have, you'll use that. Again, then after the technique, you will see under finding, it's a common text which is more comprehensive. So we are saying that we are looking at anterior, posterior, medial, and lateral aspect. We're looking at the tendons in long and short axis. We're looking at the joint, and for any abnormality like excess fluid, loose bodies, synovitis, bony abnormality, and we are also using color Doppler. So this paragraph pretty much sums up and says that, okay, you are doing a complete examination. So this template is meant for complete exam, which is CPT code 76881, which is a complete exam. Then we get into the specifics. So this is an elbow template. So we start by writing what cross-sectional area you measured in the nerve, if that's relevant to your exam. Like I said, if someone is coming for a musculoskeletal pain, non-neural symptoms, you don't have to have this here. You can delete it. Going to the second page, now you will see I have divided into different aspects. Now, initially we had 1A, 1B, 2A, 2B, different numbering for each protocol, shoulder, wrist, and elbow. I have eliminated that because that has created a lot of confusion, and I don't think you can fit everything under those headings for every patient. So it's better to keep different aspects. So you will see anterior, medial, lateral, posterior in different templates. And then I have some important structures which we normally image. So like in anterior elbow, you will look at the joint. So you are saying, okay, you looked at anterior joint surface and it appears uniform with no evidence of cortical irregularity, cartilage erosion, joint diffusion, or loose body, and the recess do not have excess fluid or loose bodies in it. Distal biceps tendon appears intact and uniform thickness, and there is normal echo texture. And wait, okay.
Thank you.
Do you have a question?
No, I just didn't. I wanted to be able to ask one should it come up.
All right. Okay. So yeah, so I have divided that section, the finding part, and I took the unremarkable, remarkable out because there was a lot of problem with Mac and PC format. So I think it's fine to not use that. Again, this can be changed based on what type of patient you're seeing. Maybe you don't need to do distal biceps tendon in that patient. So you will delete this line that on distal biceps tendon, and you will leave the joint part and the soft tissue part there. So this is again, a dynamic space. You can change it based on the need, change based on what type of exam you're doing. On the lateral aspect, we look at the joint and common extensor tendon and also radial collateral ligament. So that language for that. So everything is normal in all the templates. Okay, so if there is deviation from this normal, then we mention that in this space here. And there are so many possibilities. So no template can be comprehensive and all inclusive. So there will be some patients where you will have to make some major changes in these template. So just know that. Okay, so now let's go in from anterior, lateral, medial. On the medial side, we look at flexor tendon, common flexor tendon origin. We also visualize anterior band of ulnar collateral ligament, ulnar nerve, if that's relevant to your exam. It's a good habit to screen the nerve, and you may not have to do very extensive scan of ulnar nerve, but it's good to just view it so that you know what is the position of ulnar nerve in relation to other soft tissue adjacent structures, and if there is any structure which may compromise ulnar nerve. And if you have measured the cross-sectional area, then you can enter that in this table here. Going posteriorly, we look at only one tendon, single big tendon, triceps tendon, posterior joint and recess, and then you conclude all the abnormal findings. So you don't have to list each and everything. In impression, impression is basically what is wrong with the patient, or what is wrong with this exam. So here we write only what's abnormal. We don't have to repeat what's normal. So you can use this template for elbow and change it based on the type of patient you're scanning. Now let's go to shoulder. So shoulder is the only exception where I have not divided the finding into anterior, posterior, medial, lateral, because remember, shoulder is one region where we want to do that systematic, comprehensive examination of the tendon. So you start with long head of biceps tendon, go to subscap, supra, infra, because these structures give clue about indirect clues about what else can go wrong, or other intra-articular pathologies. So yeah, you want to start with long head of biceps tendon in shoulder, and that is a very important structure in shoulder. So in shoulder, you will see I have specific tendons mentioned here and what their appearance is, and you can elaborate on this. But a shoulder, very important part of shoulder examination is rotator cuff tendon evaluation, so we have to mention them separately. And so you have long head, subscap, supra, infra, AC joint, and then dynamic testing. And of course, you can include teres minor, or if you want to include the ligament, if that's relevant to your exam, you include that in the findings. And the first part again is the same. First page is pretty much the same. This language is slightly different in the finding for this is more specific to shoulder. And then impression is where you would write what is the conclusion of the findings. Now let's go to the wrist. And wrist again, first page is same. We measure median nerve, so I have a table here where you can write the cross-sectional area measurement of the nerve. And now wrist is again divided into anterior, posterior, medial, lateral. But as you know, wrist dorsal compartment span from radial to ulnar side and also span the entire dorsal side. So it's a little strange body part where you cannot really exactly divide structures based on volar, dorsal, medial, lateral, because there are some structures like dorsal compartment. First dorsal compartment is actually the radial aspect of the wrist. So I have volar wrist where I have median nerve, structures of carpal tunnel, joint, structures outside the carpal tunnel like ulnar nerve, flexor carpi radialis tendon. And then on the radial side, I have mentioned radial aspect of the joint as well as first dorsal compartment, because that is the radial side of the wrist. So first dorsal compartment can be included on the radial side. Then everything from second dorsal compartment to fifth dorsal compartment is in the dorsal wrist. We don't have to check all 6 dorsal compartment tendons in every wrist. Whichever compartment is relevant to you, you scan that. Important ones are first, fourth, and last, sixth. And that includes radial side, dorsal side, and ulnar side. So first is first dorsal compartment, which is decurvent tendons. Fourth is right in the mid portion on the dorsal aspect of the wrist. So that's dorsal wrist. And ulnar, the sixth dorsal compartment, which is the last compartment, is extensor carpi ulnaris, and that tendon is on the ulnar aspect. And you can also visualize part of TFCC complex in that region. So that's the wrist, all the aspects of wrist. Then going to digits, if you are doing a digit scan, then you can include palmar digit or dorsal digit. Let's say that patient only has problem in one digit, first digit, or let's say second digit, then you will say palmar second digit or dorsal second digit, and then and you can duplicate this if there are more than one digits that you're scanning. Another common site for pathology is first CMC joint or basal joint. So I have that included in the findings. But again, this can be changed based on the clinical scenario, and these findings can be changed. In impression, you will summarize what are the abnormal findings. So that's the wrist. Now let's move to lower extremity, so hip. Okay, so again, first page, similar. Hip I have divided into anterior, lateral, medial, and posterior. If you do not scan everything, then you have to change the findings to match with what type of study you did. On the anterior aspect, we have hip joint. You're looking at the articulation, capsule ligamentous complex, looking for any fluid distension of the capsule or any fluid outside the capsule, which can be bursal effusion. Lateral side, we're looking at greater trochanter. That's a big part on the lateral aspect. That region of gluteal tendon insertion, gluteus medius and minimus. So you're evaluating greater trochanter. It's bony facets where gluteus medius and minimus inserts. And going posteriorly, you're looking for any fluid collection, which can suggest trochanteric bursal effusion or trochanteric bursitis. Medial, most of the time we don't do as part of the hip. If it's indicated, you can scan adductor muscle origin at the pubic tubercle, iliopsoas tendon scan. So we see iliopsoas on the anterior aspect. So what you have to do to look at the tendon insertion is you have to have the patient in external rotation, so slight flexion of knee, like 45 degrees, and external rotation of the hip to expose or to bring the lesser trochanter superior towards your probe, so you can visualize the insertion. So iliopsoas tendon inserts at lesser trochanter, so you have to have external rotation of the hip to visualize that. So you will see iliopsoas is mentioned in the medial hip, and you will also see iliopsoas mentioned here at the anterior hip. And that's here, where is it? Yeah, here, overlying iliopsoas muscle and tendon. So I have muscle and tendon unit mentioned here, and I have iliopsoas tendon mentioned under the medial hip, and that's because we don't really look at the bony, the insertional fibers or the distal aspect of the tendon on the anterior aspect. We look at the muscle tendon junction at that level, or some tendon and some muscle tissue. So if you have to examine the tendon, you have to go a little bit more distal. Now on the posterior aspect, we have sciatic nerve, piriformis muscle, hamstring tendon origin, and so that's posterior hip. So that's anterior, lateral, medial, and posterior. Now on the medial side, you can also include, I think you can also include groin. If you're imaging groin, let's say inguinal area for any abnormality, that can also be included here. And also there are other structures that can be included on the anterior aspect, like structures attaching at anterior superior iliac spine or anterior inferior iliac spine, like rectus, femoris muscle, or PFL, ITB, proximal portion. That can be also included on the anterior side of the hip. And then you summarize your abnormal finding in the impression or interpretation. So that's hip. So now after hip, let's go to knee, and then I'll show you ankle. And you can ask me any questions if you have. I can answer those right now if you want me to.
So basically, Mohini, you just want us to take out anything that we didn't do in those sections. If we didn't scan something, we take it out. If we added something, you want us to type it in.
Yes, yes. Yeah. Yeah, so for every time you write a report, you want to go over these findings and just make sure that you have, you don't have anything that you're not testing, and you're also not missing out something that you tested and you did not mention here. So let's say,
Yeah,
like,
I think it's very helpful.
Yeah. So if let's say whatever I have here, you did something more than that, or maybe something which is not mentioned here, and that structure was not abnormal. So you don't have to write that under impression, but you should mention it in the finding that that structure was normal. So yeah.
Mohini? So not all aspects of the joint have to be examined to have it as a comprehensive examination under the CPT code? Not necessarily.
So it says complete assessment, but it doesn't say. So if you look at the language, actually, I have the language right here. Can you see the slide? Let me see audience view. Okay, can you see
Yes.
this slide, right? So yeah, this is the language, complete assessment of the joint or anatomic region. So evaluation of joint, synovium, bone, muscle, tendon. It doesn't really say that you have to scan each and every tendon or muscle or ligament. Yes.
Okay, thank you.
Okay, so someone else is also muted. David. Okay, okay, I think I unmuted you, David. You can speak.
Thank you.
Okay, so yeah, so complete assessment. This is the language. It says evaluation of joint, bone, muscles, tendon, ligament, fascia, capsule, and other supporting structure. So if you look at the first page of the template, look at this paragraph here. This paragraph where this is the paragraph where you will find this language that, okay, we examined the knee and we look for abnormality on the anterior, posterior, medial, lateral aspect. Tendons were evaluated and joint were evaluated and other soft tissue structures. So this language is included. Sorry, this not this one. Yeah, so this language is already included in the template. Evaluation of joint, synovium, bone, muscle, tendon, and you will also see this language here in the impression. So it doesn't mean that you have to check each and every structure, but it has to be comprehensive. It cannot be like, so let's say you are doing ankle and you only looked at anterior joint and 3 tendons on the anterior aspect and nothing else. That can be questioned. But let's say you did anterior aspect of the joint and anterior tendons, tarsal tunnel, peroneal tendons, and then you missed Achilles tendon because that was not of any concern. I think that can still be considered complete exam because you still examine majority of the important structures around the ankle. Because the posterior aspect, peroneal and Achilles, and even medial, if you look at the medial aspect, you can get some visualization of the Achilles tendon if you go that far. If you have that much width in your, if the footprint is wide, you can get that. So if you miss one tendon and you image all other important tendons of the ankle, that still is a complete study. So 76881 is not defined by number of the scans and number of images or pictures, and it is not defined by how many structures. So there's no number associated, but it does say complete assessment, and it is based on the clinical presentation. You can, I can forward everyone AIUM practice parameters and the other standards of musculoskeletal ultrasound article, and you can look at it, and that'll give you a good idea of how these exams are defined. Now, on the other end, the second code, which is a limited code 76882, it is anatomy specific. So here you're imaging only one structure. So if you do a NeuroMSK, that would be 76882, which is limited exam. Okay, so let me go over knee and ankle, and then I'll show you the NeuroMSK templates after this. So knee, again, the first page is same. It has that broader comprehensive language that we look for abnormality in the joint and tendon and other supporting structures, and use of color Doppler. And then I have divided it into anterior, medial, lateral, and posterior. On the anterior, I have quadriceps tendon, patellar tendon, suprapatellar recess, and other areas where you can get bursal effusion, like prepatellar, deep, and superficial infrapatellar bursa. So that's anterior knee, everything, the entire thing. Actually, I miss a sunrise view. You can include sunrise view also here. So, joint and soft tissue structure on the anterior aspect, everything is included under this anterior knee finding. Then on the medial side, we have medial collateral ligament, medial meniscus, medial patellar retinaculum, pes sensorin tendons, and bursal region. On the lateral side, we have lateral collateral ligament, lateral meniscus, popliteal tendon, lateral patellar retinaculum, biceps femoris tendon, and ITB. On the posterior side, semimembranosus and mediogastrocnemius tendons, because this is the area where the Baker's cyst originates between the semimembranosus and medial gastric tendons. That's where the neck or the stalk of the Baker's cyst is. So it's important to visualize that. Then you can look at posterior joint area, sciatic nerve, tibial nerve, and common fibular nerve, if that's relevant to the exam that you're performing, and then you summarize your abnormal findings in here. Okay, moving to the ankle. Okay, here we go. So ankle, same thing here. First page, similar language, more comprehensive language to include all the important structures, a table for posterior tibial nerve. Then I have anterior, medial, lateral, and posterior ankle. On the anterior aspect, joint, tendons, and ligaments. So anterior ankle joint, 3 tendons, tibialis anterior, extensor hallucis longus, and extensor digitorum longus. Then anterior tibiofibular and talofibular ligament. On the medial side, contents of tarsal tunnel, so tibialis posterior tendon, flexor digitorum, and flexor hallucis longus, posterior tibial nerve, and deltoid ligament if that's relevant to your exam. On the lateral side, we have peroneus longus, and peroneus brevis tendons, and calcaneofibular ligament. Posterior aspect, Achilles tendon, bursal region, and posterior joint. Then moving to the plantar aspect, plantar fascia, and then you can add, if you're doing midfoot or you're doing digits, MTP regions, that can be added under the findings here. Then we summarize that. So that's all 6 joint regions: shoulder, elbow, wrist, and hand, hip, knee, and ankle and foot. If you have any questions so far with these template, which are meant for comprehensive assessment, 76881 CPT code, you can ask that. No questions? Okay, it's possible that you may have some cases where you're only doing one structure, so you may have to edit these templates based on that. So let's say you have a patient post-op with a specific tendon repair, and you're only imaging that tendon, that specific tendon, then you have to change this template to based on the type of study that you're doing. Now let's look at the NeuroMSK templates. Okay, so first page looks similar. You have to write indication why you did this exam, why you're doing this exam. So you will write what type of presentation, numbness, tingling in the distribution of median nerve, or other findings, important findings from your clinical exam, like Tinel's other provocative tests. Any relevant history, especially if there is any surgery around that area, you want to mention that. Comparison, then the type of probe you're using. If you have anything different than 6 to 15 megahertz, a linear probe, or you have to change this language here of the technique. Then these parameters are based on AIUM parameters, so we leave this here in the finding. And then you will see the language here is different. It's meant for nerve, but I have put a general language. This can be changed for a specific nerve. So nerve, we examine it in short and long axis, and we are looking for any focal changes in the signal, as well as focal changes in the caliber of the nerve. So any focal enlargement or swelling, any signal changes, any physical deformity or constriction sites along the course of the nerve, any possible adjacent space occupying masses. So that's what we have here. And we don't just do short and long axis. You also look for any other potential source, any dynamic compression. So you do dynamic examination of the nerve to check for gliding relative to soft tissue around it, and look for any subluxation dislocation. This is more relevant to ulnar nerve because the ulnar nerve tends to sublux in 15% of population, so you would write that. If let's say this is not relevant to your exam, then you delete that here. And you are also looking at surrounding soft tissue, at least in the near vicinity of the nerve, to make sure that there is no other extrinsic source of compression. Then you mention where you image that nerve. So for median nerve, we image the nerve at the level of wrist or distal wrist crease, and we also follow it a little bit into the palm area. But that's the area where the cross-sectional area measurements are standardized. So you mentioned that you write what the cross-sectional area is. If you are doing ratio, wrist to forearm ratio, or any other measurement, you are free to use those measurements. You can include that here. So far, these are the most clinical utility of cross-sectional area is much higher than other measurements. So you get more out of this finding than others, but you can definitely include as much data as you have for that nerve. So if you're doing ratios, you can include that here. And then in impression, you will summarize how does the nerve look, if there is any focal enlargement, if there is any abnormal signal or structure within the nerve or around the nerve. That's what you mentioned here. So this is going to be a shorter report because you're just imaging on one structure. And this is an assumption of when you do ultrasound, for any ultrasound, you are always doing two planes. So that's why I have this thing here. We don't have to repeat this again and again, short and long, because you are supposed to do short and long for everything. So I don't think we need to be too repetitive in our findings or impression that we are repeating long and short again and again. You want to give a good summary and precise information at the end. I'm going to just look at some questions because I think some people typed some questions. Okay, so Bill is asking, we no longer refer to LAX and SAX. Yeah, short axis view and long axis view is LAX and SAX. Or you can say short axis and long axis, as you can see here. I don't know if you mean by, I think you're probably referring to the previous finding in the previous template. We had the findings listed like that, like long head of biceps tendon LAX, long head of biceps tendon SAX, and that was just so that people know, okay, when you're following the protocol, this is your first image, second image, so it correlates with what you see on the template. But yeah, short axis, long axis is SAX and LAX. That's the short form or abbreviation for that. You don't have to be repetitive on that, so you can just have like structures there. And in the beginning, under the finding, we are saying we are doing short and long for everything, so you don't have to repeat it again and again. Okay, now let's move to ulnar nerve. So same thing here. First page, you have to mention which nerve you measured and what are the cross-sectional area measurements, and if there is any focal changes in the nerve signal or caliber or any physical deformity or space occupying lesions around the nerve, and how's the mobility of the nerve. So same thing here. And the last one, which is at the ankle. Okay, so this is ankle, posterior tibial nerve. So tarsal tunnel syndrome, if you have patient with tarsal tunnel syndrome and you did their EMG, you can follow that with NeuroMSK, measure their posterior tibial nerve at the tarsal tunnel or medial ankle. And record those measurements and also look for any focal changes in the nerve at that site. So look at nerve in short and long axis or the structures around it. So same thing here. So that concludes all the 9 templates that I sent you. Any questions so far? These NeuroMSK templates can be, you can use them for any other nerve. These are the most common nerves that we image. Median nerve at the wrist and ulnar nerve at the elbow and posterior tibial nerve at the ankle. But let's say you're doing not so common nerve, maybe you're doing posterior interosseous nerve or suprascapular nerve or common fibular nerve. You can use the same templates, just like change this text here, this text here, you edit some of the text here, and you can use the same format for the other nerve. Okay, so any other questions from the template so far?
So the NeuroMSK templates, is it anyway we do comprehensive examination when we do the other aspects of the joint? So are we supposed to complete the NeuroMSK template separately besides?
No.
Okay.
No. So if you did a complete exam of, let's say, wrist, and you have also looked at the nerve and measured, you don't have to have a separate NeuroMSK for median nerve. Is that what you're asking?
Yes. So when do you do only NeuroMSK?
So let's say you did an EMG and you have a patient. Yeah. So as an adjunct to EMG, or let's say you have some contraindication and patient cannot have EMG, and you are only interested in their nerves, and you don't have any other reason to do joint ultrasound to look at the soft tissue structures, and you only want to look at nerve, you will be doing NeuroMSK in that case.
Okay. Thank you.
Okay. Any other questions from the templates? Okay, so I'm going to let's practice some report writing now. So let me give you a quick overview of, so let's use a shoulder as an example, and I'm going to use just like a quick overview and quick information about how we classify tears on his rotator cuff based on ultrasound. So remember this image from module 2A. This is a normal shoulder, a supraspinatus, a long axis view on the left, and this is a short axis view on the right. When patient has a focal defect on the upper part of the tendon, which is confirmed in long and short axis, that focal partial tear is called articular sided partial tear, because this is where the articular cartilage is, right? This is where the bursa is. So failure of fiber on the articular side or the deeper side of the tendon is the articular side. If the fiber failure is on the superficial side or the top side, that's the bursal side, because bursa overlies the supraspinatus and articular cartilage is deeper to the supraspinatus. So that's how they're localized based on where the focal defect is located. I have one question here. So David asked if you prefer we start using the new templates. Will these be available? I think they are in your Dropbox already. This morning, an email was sent out to the entire group with these template as an email attachment, and they're also in your Dropbox under 2019 updated MSK. So you should have those. Yeah. So yeah, you can use these. Okay, so this is articular sided. So look at the image here. The yellow arrow is pointing at the focal defect, right? And the yellow arrow is pointing focal defect in short axis. So the top image is the long axis, the bottom image is the short axis, and then you can put a caliper here, the calipers, linear calipers, and measure this focal defect. And so let's say if, this focal defect you measure 3 millimeter and this focal defect is 6 millimeter, so you can define this defect as 3 millimeters by 6 millimeter articular sided partial tear. So now let's attempt to write a report. So can somebody try to write or try to formulate an impression for this type of finding? So let's say you did a shoulder exam and everything else was normal, and this is the only abnormal finding you have. How will you write this in your report?
There's sonographic evidence of a hypoechoic signal at the bursal side of the supraspinatus, measuring 3 millimeters by 6 centimeters, indicating a partial tear, partial bursal sided or partial articular sided tear.
Yes. So yeah, that's right. So that's how you will write the report impression for this specific finding. So you can say there's a focal anechoic defect, or you can say focal anechoic region or area. There are different terminologies that you can use, but the important thing is you localize where the defect is, and you then classify it into partial or complete. And if you can see it as a focal defect, then I think you should measure it. Sometimes the defects are not very clear. In those cases, it's hard to put calipers and measure it, but here you can see a clear defect. You should be able to measure it. So this is how you write it in the report template, right? So what I'm going to do actually is I'm going to go to the report template and I'm going to type it there so you see how you write these findings in the report. So here you will write patient name, date of exam, date of birth, all the patient demographics. Then you will write here the history, what type of presentation this patient has with the right shoulder or left shoulder, and what physical findings are relevant physical findings, and then everything else is fine, so you leave it as is. And in supraspinatus you will change this language here to you will say supraspinatus tendon shows loss of fibular echotexture with focal defect on the articular side, measuring 3 by 6 millimeter. Okay, so this is what you change in your findings, and then what Vicky said will go here under the impression. So see what I'm saying? You have to change that in the finding and impression, and it can be the similar thing also here. You can write the same thing here. So this is how you will change it. Okay, now let's go back to where were we? Okay, here. Now let's go to the next one. Now this time the focal defect is on the bursal side. See, this is where the bursa is, this is where the articular cartilage is, and these are the tendon fibers. And this is the defect which you see on long axis. Can you confirm that in short axis? And on the ultrasound image, you can see the focal defect on the bursal side, or the superficial fibers of the supraspinatus show focal defect, and the same is confirmed in the short axis. Now we put the caliper and we measure it to be 5 millimeter by 7 millimeter. So now try to formulate an impression for this one, this finding. Anyone?
There is sonographic evidence of a bursal side, or I'm sorry, there's sonographic evidence of a focal hypoechoic defect on the bursal side of the supraspinatus tendon near the insertion, measuring 5 millimeters by 7 centimeters.
Okay. Yes, so yeah, so this is how you write this impression for the bursal sided partial tear. So you identify it's a partial tear, you define, localize where the tear is, what is the size of it if you can. Like I said, in some, when this is acute, when you get the patient which is not so acute, subacute or chronic, there's granulation tissue and collagen fiber that are disorganized, so you cannot see the clear defect. In that case, it'll be hard to put the calipers. But if you see a focal, nicely defined defect, you can put the calipers and measure that focal defect. So that's good. Yeah, that's bursal sided, articular sided. Now we have another partial tear, which is mid substance or intra substance. So this tear is right in the middle here in the long axis. In short axis, you again confirm it in short axis. Now let's try to formulate impression for this one. Anyone?
There's sonographic evidence of a hypoechoic signal that is consistent with an intra-substance tear in the supraspinatus tendon, and we didn't measure it.
Yeah, and you can measure it, but you will say there is a focal hypoechoic defect.
Focal hypoechoic defect.
In
Okay.
the mid substance of the supraspinatus tendon.
Rather than the intrasubstance.
Yeah, then you will say it. Yeah. So here the cortical margins are smooth. If there are those findings, you can also include that in your impression. So here you don't see the cortical margins are smooth, so it's just the focal defect that you're seeing. But there can be more than these findings. There can be how did I reach here? Sorry. Yeah, so there may be increased vascularization. So you may see increased angiogenesis if you put the color Doppler on. There may be some bursal fluid on top of it. So it can be a little bit more complex than what you see here. So you want to include that also in your impression. Okay, now let's go to full thickness. So here there is no tendon attached, right? So you see there's absence of the tendon here. So now let's try to formulate impression for this full thickness tear of supraspinatus.
Would you call that more of a diffuse hypoechoic signal?
So I'll first start by saying that I don't see supraspinatus. So I'll say there's non-visualization of supraspinatus tendon, and then you can define like what type of signal you see there. But your first thing that you say is if there is a tendon or not. So
non-visualization.
Yeah, so this non-visualization is the important thing. So you want to say that before you define the tissue in that area or the fluid or other findings. So there is non-visualization of supraspinatus tendon to its attachment side, suggestive of complete full thickness tear, and the tendon stump has retracted proximally because you cannot see it. So that's another thing that you will write it. Sometimes you can see tendon stump right here. So in that case, you will measure, you put a caliper from here to here and say, okay, the stump has retracted 2 centimeters from greater tubercle. In this case, you don't see it, so you will say that you don't see the proximal stump, so it has retracted further proximal. And then you will also define the cortical irregularities and defect in this region. And this is all effusion. And you know this is effusion because you see cartilage interface sign here, right? So this is then after you address the tendon issue, you write about other surrounding interface like bony interface, cartilage interface, and the fluid in that region. Okay. Okay, now this one is. Okay, now let me also show you some examples of okay, so you can quantify structures, whatever structures that you see on any space occupying lesions, cystic mass, effusions, you can measure them, and you can mention that here. So this is a knee exam, and as you can see, I have first defined what kind of mass I see. So this is localized hypoechoic mass of heterogeneous texture on the lateral aspect of the left knee, originating from the lateral joint space, suggestive of soft tissue mass or possible parameniscal cyst or synovial cyst, measuring 5.79 by 4 by 1.09 centimeter. Clinical correlation and further imaging with MRI warranted. So especially when you see something, any finding which you don't see complete structure with ultrasound, you have to make sure that you write that patient need further imaging. So any intra-articular pathology, like if you see meniscal pathology in the knee, parameniscal cyst or paralabral cyst in the shoulder, you have to write that this patient needs more than ultrasound. You need MRI scan for this patient too, and then you go on and define or describe what other soft tissue structures appear in the knee area. So linear calipers can be used for anything that you want to quantify, and also for monitoring purpose. So let's say you are imaging someone's tendon, Achilles tendon, and you're treating them, and you want to repeat the exam in 6 months to see if the tendon swelling has subsided, or if the tendon looks better than before. Then you have to have the measurements at the start of the treatment and 6 months after. So in that case, you can have medial, lateral, and AP measurement of the tendon. You don't need cross-sectional area measurement for anything other than nerves. Okay.
Dr. Rawat, how often would you rescan someone who may have like a partial thickness tear or something like that?
If they're not improving, they're not responding to the treatment. So it depends on if they're responding to treatment or not. I would say like partial tear, you don't have to repeat it unless you need to. If they're not responding to treatment, or you're trying to find out something more, or something has changed in the clinical picture. But you don't just do a repeat exam as a standard for partial tears.
Because I have a patient that I sent you recently on who has a partial thickness tear, and we've been seeing her for about 6 weeks now, and she's feeling a little bit better, but not very much. She wants to know whether or not it's getting better.
So how many weeks has that been now?
Almost right at 6.
6 weeks. So 6 weeks, like for reimbursement purposes, it may be difficult to justify. You can scan it if she's getting worse or shows little to no improvement. I would give at least 8 weeks before you see some changes. Like I said, if you see something dramatically changing in their clinical picture, you can repeat it, even if it's early. But as long as she's not like worsening or showing no improvement at all, you should wait. There is no like I really cannot give you a specific answer of how many weeks, but I'm just like probably I think you should give at least 4 to 8 weeks. Yeah, I don't have any clear-cut answer for this one.
Okay.
And Mohini, when you rescan, would you just scan the affected area, and then it would be a limited, not a complete scan again?
Follow-up exam is usually limited exam. Yeah.
Right, limited exam.
Okay, so. All right, so now let's look at this supraspinatus. So on the left you have short axis view, on the right you have long axis view. Now tell me what you see here and try to formulate an impression for this supraspinatus. Now this one is not nicely clearly defined focal defect in the tendon.
More of a cortical irregularity.
Yep, there is cortical irregularity, that's correct. What else?
Increased hypoechoic area on the bursal side of the long axis.
You mean
Right
here?
there, yes, exactly. That line right there.
Now, I'll tell you, this one doesn't concern me because, okay, here it may look a little exaggerated, but look at the short axis view. It doesn't look too bad, right here?
Okay.
Now, this one is bad because this is refraction artifact. So this area, we're not hitting this area 90 degrees. It's not parallel to your probe. So this is going to be hypoechoic, but look at here. So that's why we need short and long axis for everything, right? Here it looks a little bit bad, but not so bad in short axis. So then it doesn't concern me here. Okay, so cortical irregularity, that's good. That's number one. Tell me about tendon. How does the tendon look?
Loss of echotexture of the fibrillar pattern, fibrillar texture.
Loss, you said loss of, say it again, Vicky.
I just said the fibrillar pattern, the echotexture of it is, yeah, I don't know what I said.
There's a loss of fibrillar pattern.
Fibrillar, yeah. So does it look normal tendon, like in terms of normal tendon shape, like bird beak? Remember, we see bird beak view in supraspinatus. There's the tendon contour. It's not same. Look, you normally see a concavity here, right? Yeah. Oh, sorry, convexity. Right. I'm sorry, convexity. It's not convex. So this is a partial tear which is not acute, it's chronic. So you don't see nicely defined focal hypoechoic or anechoic region or focal defect. But we know that this tendon is not healthy. Number one is we see cortical irregularity, and then we see the tendon doesn't look normal in shape or contour. There is no convexity of the tendon here. It doesn't look like bird beak. It's more like flat structure here. And although there is some hyperechoic fibrillar, but it's not how you would see like a compact hyperechoic echogenic signal is not there. So this is the image of a tendon which has a partial tear, but it's not a chronic, it's not a acute partial tear. So this is suggestive of a partial tear because of the indirect signs that you have a cortical defect, which you see in short axis right here and long axis here. You see the change in the shape of the tendon, loss of this convexity here, and hypoechoic, diffuse hypoechoic signal within the tendon. So, okay, so now we know what we see here. So let's put it together.
Do you describe the chronicity of the, do you say it's a subacute or acute or chronic condition?
We don't try to get too much into it because, so there is also some age progression. So you have to put everything together. Like clinical picture, what's the age of the patient, what's the mechanism of injury, because it's possible some people have some chronic wear and tear degenerative changes, but they can re-injure something. So there is some degeneration in this tendon, but you'll have to see more than this to comment on that. But we don't really define, like we define an EMG, acute, subacute, chronic. You can broadly say it's more chronic or more acute or focal, but we look at other indirect signs. So you will look at the fluid in the bursa, you will look at fluid in the sheath of the long head of biceps tendon. So LHB tendon is a very important structure in shoulder. It gives you indirect fluids. If you see more fluid, then there is something acute going on in this degenerative shoulder picture.
So
Okay.
can you go over the partial tear aspect of this image again? Because I mean I thought it looked, other than the
First,
degenerative changes, it didn't look like a partial tear to me. So that's why.
so let's say you have 100 fascicles in a tendon, and now out of 100 you have 20 torn, right? So so if the thickness of a tendon with 100 fascicle is, let's say, 10 centimeter, what would be the thickness of tendon when 20 of those fascicles are torn?
8 millimeters.
Right? So it will be less than that, right? It becomes thin. So that's when you see the tendon is thinner than the normal tendon, and you can quantify that. So we have a normal rough range of 6 millimeter thickness, so you can measure that. But also looking at it qualitatively, you don't see the normal bird beak that you see. So the convexity is lost. So there is loss of some tendon fibers from this tendon, right? So that's one of your clue. The second one, there's a focal cortical defect, which you confirm in short and long. When you see cortical defects, these tears are usually tiny bony avulsions from the insertion site. So if you see cortical defects, you are looking at some type of partial tear. It can be, the degree of partial tear can be different. So these are two clues, right? So if you put that together, you know that there is some type of partial tear going on. If this tendon was just degenerative tendon and no tear, you wouldn't see much of the cortical defect at the insertion site, and you will see swelling of the tendon and heterogeneous appearance. So we are lacking the swelling part, and we're lacking the bone part of the tendinosis picture. So so we are thinking more in terms of partial tear versus just plain degeneration.
Okay.
Hence, okay, now let's put it together and let's formulate an impression based on what all we discussed so far. How do you write this impression for the supraspinatus? Anyone?
I think you start by saying there's a loss of fibular pattern and a loss of convexity and thickness in the tendon itself, suggestive of a partial tear.
Yeah, that's right. So you'll comment on how the tendon looks. You'll say there's loss of normal tendon contour, normal fibrillar pattern, tendon. If you measure it, you can say it appears thinner, or you can also sometimes, if it's significantly thinner, you can always say there's thinning, significant thinning. And if you scan infraspinatus after this, you will also see you will have a comparison with infra, because supra is supposed to be thicker than infra. And let's say in this case, although you did not put calipers, but you see infra and supra almost same thickness, then there is definitely some thinning of supra in that case, because supra is supposed to be thicker than infra.
You would also want to include the cortical irregularity in your impression, wouldn't you?
Yeah, that's right. Cortical irregularity, you can say cortical defect. Right, so you will also see that there is associated cortical defect, and so that suggests partial tear of supraspinatus. Okay. So let me put it all together. So you'll say there is loss of normal contour and loss of normal fibrillar pattern of supraspinatus with some diffuse hypoechoic signal and associated cortical defect suggestive of partial thickness tear.
Would you say chronic partial thickness or just partial thickness?
So then I'll have to actually look at other structures to say that, but it's more chronic. So I will also look at what type of history the patient presents with, if there is any mechanism of, if there is any recent traumatic or any recent exacerbation of symptoms, if my sonopalpation at this area generates pain, or if they complain of pain, I do a lot of sonopalpation to clinical correlate, because if you're imaging someone 50, 60 plus shoulder, there is always going to be something wrong there, but doesn't mean that that's the source of pain. So make sure when you find something abnormal, you try sonopalpation, you ask more questions. So I have to do more than that to say that. I may not, so I tend not to write too much on the temporal aspect of it, unless it's relevant. So let's say they have, what do I say, like they're not tender here, or they don't have isometric weakness of external rotation, they don't have any functional limitation of functional range of motion limitation, anything that would suggest something more significant for supraspinatus pathology, then I will say that it's most likely a chronic pathology, right? Because what we're looking at structure and how the structures are present, how the structures look like, but we don't necessarily look at the causal relationship. So it may not be the cause of their discomfort or functional limitation. So you need more than just 2 images to write that or say that. Make sense?
Yes.
Yeah. So yeah, we need more information. 2 images is not enough, but it does look something which is going on for a long time. So let's say this patient presents with some recent onset shoulder discomfort. Maybe they were a history, something like that, where they were doing something in their garden and that triggered the pain, and now they present to you. Then I will look at the bursa and their long head of biceps tendon sheath and other things. If I see fluid there, then there's possible that they're re-injured, and maybe the partial tear. So they had out of 120 fascicles torn before, but now they torn like another 10 or 20 more after that injury. So you can re-injure already a chronic. Let me say it again. You can re-injure something, right? So if something is partially torn, doesn't mean you cannot tear it further. You can still have a re-injury in that area, or you can progress that tear from partial to a high-grade partial tear.
Dr. Rowat, would you compare to the other side for just the supraspinatus thickness, or you just look at the infraspinatus and compare that way?
Yeah, that's a great thing to do. Yeah, you can compare on the opposite side. Yeah, so it depends. If my question is already answered with just doing right shoulder, let's say one shoulder, I don't. But let's say this is borderline, and I'm not sure if I should call it thin. Then I will quickly look at the opposite supraspinatus and then measure the thickness of contralateral supraspinatus, and then say, okay, this is thinner than the opposite side. So yeah, it depends. If doing the scan on one side doesn't answer all the questions, that you may have to do contralateral comparison.
Okay. Thank you.
Yep. Okay. Any other questions? So far, it's already 8:38. I will be doing more report writing webinars now, so I'll have like images and we can discuss the findings. I think that helps everyone to just brainstorm and look at the findings together and discuss. But if you have any questions, you can email me, and if you have any questions about the templates or anything else, let me know. We can answer that right now. No questions. Okay, well, if there are no questions, then I'll end the webinar right now. And